Hello all, my name is Doshi and I'm an endovascular and coronary interventionalist. Today I'll be giving you all a bird's eye view of contemporary data on SFA interventions, focusing mostly on native SFA disease. The purpose of this talk is to give you all a general foundation and framework of what's to come throughout the rest of this course, the rest of the day, and the entire conference. I have no relevant financial disclosures, but it's important to realize that the SFA is not just a straight vessel. There are bends, tortuosities, various mechanical stresses, and torsional forces that play a big role in which therapy is best suitable for the disease state you're dealing with. The way to approach SFA interventions has changed throughout the years and relies on various factors. However, there are certain basic principles and fundamentals that you should be aware of that will help guide your decision-making when taking care of these patients. As you can see, a variety of factors on each level play a role in determining your treatment strategy, and the algorithm to treat SFA interventions is dynamic, as are the treatment modalities. So since the 2000s, the number of endovascular therapies have increased dramatically, with more technologies being developed as we speak, and I'm sure you'll learn about all these technologies in this course. What we already know from past data is that POBA alone for destination therapy is simply inadequate. It has a high rate of recoil, dissections, and also high restenosis rates. Currently, our decision algorithm revolves predominantly around drug-based technologies, biomimetics, and scaffolds. We now know that the success of your destination therapy really depends on your vessel preparation. Vessel recoil is one of the main determinants of treatment failure, and optimal vessel preparation is important for improving drug uptake, reducing elastic recoil and dissections, and improving luminal gain. We now have intravascular imaging readily available to help with these decision-making processes, and a plethora of devices to help, such as lithotripsy, high-pressure angioplasty, atherectomy, atherotomy, and even laser. These devices work by either modifying plaque, calcium, differential cutting, and each have their various indications and contraindications, of which you'll learn about throughout the course. Most recently, there has been ample of data supporting the use of atherectomy, if used correctly, in limiting the amount of bailout stenting needed to achieve your goal of improved patency rates, and this is mainly because of how these devices work to modify the lesions. Currently, IVL is being very popularized in treating severe circumferential calcium prior to initiating your destination therapy. It's highlighted by its superior primary patency rate rather than PTA alone with less provisional stenting. And lastly, the data shows that using IVUS does have its benefits in improving hard outcomes, such as amputation rates and primary patency. In fact, there has been a consensus across societies that state that patients with peripheral vascular disease can benefit greatly when it's utilized. The next important aspect of SFA interventions is your destination therapy. Historically, the standard of comparison used to assess whether or not your endovascular therapy is successful or not is considered to see if the long-term patency rates match that of vascular bypass. And since PTA and prior old bare metal stenting did not achieve this, other technologies that we'll talk about were developed, and these new technologies are typically judged by both their surrogate and hard endpoints. So whether or not you have a simple lesion or a complex lesion, in today's day of age, there is a lot of data supporting the use of these devices in a wide array of lesion subsets. For example, Zilver PTX DRCT evaluated the use of drug-eluting stent over POBA and not only showed superior outcomes, but also, these long-term outcomes outperformed historical prosthetic bypass grafts. This trial was actually one of the first times we saw that primary patency rate has come close to that of vein bypass at 5 years. In fact, this was studied systematically with the Zilver PASS study and showed that there's a non-inferiority of this technology compared to knee prosthetic bypass long-term. Newer drug-eluting stents have come up, such as the Alluvia stent, which takes advantage of the fact that their device allows for a sustained drug release that provides a closer match with the kinetics of restenosis, which typically happen within the 9-month to 1-year mark. This was one of the few head-to-head drug-eluting stent trials, and although there are limitations, the overall results basically showed that both stents achieve a high patency rate and hard clinical endpoints in both short and long term. The Eminent trial showed that the polymer-based drug-eluting stent treatment was better than the bare metal stent treatment at the time, and recently, drug-coated balloons have also gained popularity as a destination therapy of choice due to the fact that not only are you inhibiting neointimal hyperplasia, but also you're not leaving anything behind. There are a few DCBs in the market, and they all differ in terms of their kinetics and the drug dosage and delivery. Most of these are paclitaxel-based, but recently there's now trials ongoing for sirolimus. Impact SFA, for example, highlighted the superiority of DCB compared to PTA in simple lesions, but these also work well in complex lesions and maintain high primary patency rates and TLR rates. At the same time, however, there is, I just want to point out that there is a higher rate of bailout stenting when using these devices in long, complex lesions. The more recent sirolimus-coated balloon offers excellent 12-month patency rates, and I'm sure you'll learn about these new devices in future talks. Other studies also support the use of drug-eluting devices to treat PAD, and the more recent sports randomized control trial compared the outcomes of drug-eluting stent, bare metal stent, and paclitaxel DCB in long, complex FEMPOP lesions. And basically, it highlighted that in these long lesions, you should consider drug-based therapy as your destination therapy. And in this particular trial, drug-eluting stent outperformed DCB and bare metal stenting, with DCB having a higher rate of bailout stenting. And this was also seen in the BEST SFA trial, which showed that there was really no difference between a stent avoiding strategy versus a stent preferred strategy. However, that even with the use of adjunctive devices to prep the vessel, there was a high bailout stenting rate with the DCBs. Moving away a little bit from drug-based technologies, I do want to highlight the Supera stent, which is a self-expanding nitinol stent that has a unique design. It resists it provides superior flexibility and strength to mimic the artery's natural movement, resists compression, and maintains a circular lumen, especially in challenging calcified lesions and in the distal SFA POP regions where there's more flexion. In various studies, real-life and randomized controlled trials, this stent has shown excellent primary patency and maintains its durability out to 3 years. A brief comment on covered stents. The ViaStar trial found that heparin-bonded covered stents such as Viabond improved long-term patency rates compared to bare metal stents in long FEMPOP occlusive disease and can be an option in challenging patients, but they do have their drawbacks. And again, I'm sure you'll learn about the details of this in the talks coming on. Another new approach in treating highly complex long SFA lesions is percutaneous transmural arterial bypass. It offers patients who aren't candidates for venous bypass grafts a percutaneous option with patency rates similar to, if not better, than prostatic bypass grafts. In fact, this was noted as well in a meta-analysis which highlighted that if a saphenous vein is not available or open surgery is not an option for your patient, you can consider this as a viable option. In an analysis by Dr. Krishnan's group, to sum it up, endovascular therapy is an effective and safe alternative to surgery in patients with symptomatic FEMPOP disease. There are no significant differences between people who received endovascular therapy and surgery regarding major adverse limb events, amputation-free survival, and is associated with lower rates of early complication and shorter hospital stay. Since this is a contemporary talk, I do quickly want to highlight the Swede PAD 1 and 2 trial, which just came out at the end of August of this year. This trial looked at both CLI patients and claudicants and basically came to the conclusion that these paclitaxel-coated devices were not effective in preventing amputation in chronic limb-threatening ischemia or improving quality of life in intermittent claudication. I'm sure this article itself deserves a discussion in and of its own, but I just wanted to highlight it here just because it's the most recent trial to come out. So in summary, contemporary SFA data support the use of an endovascular first approach to a majority of all SFA lesions. IVUS, vessel prep can help improve your outcomes if used correctly, but I think the most important thing is you need to have a vascular team approach when dealing with all these patients to see, is vascular surgery, endovascular interventions, what's the best treatment option for this patient, both short-term and what their goals are, and long-term. Thank you.